TMS is something that was created in 1985, and it has a lot of usage, or maybe the public is more aware of TMS when it comes to mood disorders.
Welcome to Peak Human Labs, where I share amazing interviews with incredible human beings who are leaders in how to optimize your health and get you to peak mental, physical, and mental state. My name is Dr. Sanjeev Goel. I'm a physician for the past 20 years, specializing in longevity, precision medicine, and biohacking. And my mission is to alleviate the suffering we all face and will encounter when dealing with illness, sadness, and loss. And to this end, I'm sharing these conversations with people who can shed light on how to live more purposefully and intentionally so that you can be inspired and create your own path to wellness and fulfillment. Hi, everyone. Today's guest is Dr. Abdul Hamid. He's a neurosurgeon who's an expert in transcranial magnetic stimulation. Today, we'll be learning all about this technology, which has been around for 40 years, but is making a huge resurgence now because of the new devices which are available, such as Exomind on the market. You'll be learning about how this stimulation of the brain using magnetic waves is being used in a number of brain and mental health conditions. We'll see you on the other side. Hi, Dr. Abdul Hamid. How are you?
I'm doing very well. How are you doing?
Good, good, good. So thank you for taking the time today to speak to myself and to educate our listeners all about transcranial magnetic stimulation. I recently got a device in my practice, which it's called Exomind. It's being used for brain stimulation. And I was advised that you're an expert in this field, and I think this is really somewhat of I know it's an old technology, but somewhat of emerging technology again. Maybe we're learning more and more uses. So I thought you might be the right person to get us more knowledge on this aspect.
Oh, absolutely. Yeah, I mean, I think it's TMS is very exciting, even though it's not
Mhm.
as new as maybe people think it is. It's actually pretty old, but I think
Mhm.
it has shown promises in certain medical application that makes it exciting to people like myself and to other
Mhm.
providers as well.
Right. So maybe for our viewers, just take us through what's your practice like now? How are you using TMS in your practice these days? And then we can go from there.
So I'm a neurosurgeon by trade. So I did neurosurgery training, brain and spine, surgeries. My focus was primarily on spine surgery, but
Mhm.
dealing with traumatic brain injury, and I see a lot of patients involved in traumatic events, sports injuries, work-related injuries, car accidents. And then we realized that traumatic brain injury, it goes undiagnosed oftentimes. And
Mhm.
people might not even recognize they have concussion. As a matter of fact, just this morning, I just saw a patient that was in a car accident almost 6 weeks ago. And she's
Mm.
seen some providers, but to her surprise, she didn't know she had concussion until we started talking to her. And she
Mhm.
realized all these symptoms that she couldn't make sense of were all part of this post-concussive syndrome.
Mhm.
Because of my involvement in traumatic brain injuries and the lack of effective treatment, because we
Mhm.
go after the symptoms, and most of these symptoms are geared toward, most of the treatments are geared toward specific symptoms, like let's fix the headache with
Right.
medication, let's fix the tingling numbness with maybe gabapentin and so forth.
Yeah.
I was like, is there anything that can maybe help actually wake up the brain, stimulate the brain cells to connect, rewire the brain in a better fashion?
Mhm.
TMS is something that was created in 1985, and it has a lot of usage, or maybe the public is more aware of TMS when it comes to mood disorders, major depressive disorder, OCD, and so forth. But then the fact that you're able to stimulate the brain cells in a non-invasive way through magnetic energy, and understanding as a neurosurgeon the brain anatomy and the different areas of the brain that we can work on, I saw a potential to say, well, what if we actually started using TMS in areas outside of mood disorders and maybe look into helping patients with traumatic brain injury, concussion? Is it going to help with all different aspects and batteries of concussion? Probably not, but I think especially the mood changes component related to concussion, some of the cognitive changes that happen from concussion. It does help, and there has been some promising result out there showing
Mhm.
that this actually works. As a matter of fact, I think some of the
Mhm.
university teaching centers, including
Mhm.
UCLA here, in the UCLA, I think they have a grant, an active grant, where they're actually looking into TMS and traumatic brain injury. So they're
Mhm.
investigating that at a larger scale. So that's how I got into bringing TMS into my practice, not
Mhm.
just in terms of mood disorder, helping people with
Mhm.
depression and
Mhm.
anxiety, general mental wellness, but
Yeah.
also utilizing for the traumatic brain injury population.
So let's take a step back and tell your viewers what happens in a concussion. Like, what's happening to the brain? How does damage happen? We sometimes, I've seen so many patients in this, and we never see anything really. Like, there's very difficult to see anything on imaging. So, what exactly is happening at the microscopic or even level?
And yes, that's actually a great topic. And the reason being is most people, including the patient I was talking about this morning, they
Hmm.
have this misbelief that you only have a concussion if your head strikes something or if you
Hmm.
pass out or black out completely. And
Hmm.
that is not true. You could have a concussion even if you didn't black out, even having a sense of a little bit of maybe seeing stars, maybe feeling like a mental fog, little disoriented. You don't have to black out completely to meet the criteria for concussion. You're going to have
Hmm.
cognitive changes that still qualify as concussion. Now,
Hmm.
in terms of mechanism, what happens during a concussion injury, there is an acceleration and deceleration. So think about, let's say, a car, a moving car at a certain speed. Let's call it 40 miles an hour, 40 kilometers per hour, right? The skull and the brain are moving in the same speed.
Hmm.
You strike something and now everything stop. That
Hmm.
stopping movement, when the skull stop, the brain tissue inside the skull might actually go through an acceleration deceleration, and that can cause jarring of the brain inside the skull.
Hmm.
That can now disrupt some of the signals through these brain cells, the communication between the communication between the brain cells,
Hmm.
forming these changes in the brain function. Some of it could be cognitive related, such as confusion, disorientation. Some of it could be mood changes, depression,
Hmm.
anxiety. Some
Hmm.
of it could be physical, such as
Hmm.
visual changes, headaches, and so forth. So the
Hmm.
true mechanism is when the brain and the skull and the speed of the brain and skull go through acceleration, deceleration, and depends on the change, the difference between the acceleration and deceleration. You can go from mild jarring, where the brain just was shaken a little bit and maybe you have mild symptoms, to extreme cases where there is actually shearing of the brain cells. We call that diffuse axonal injuries, where now all these brain cells that have all these elongated fibers, we call it axons, will go through these kind of tearing injuries. And that's what we call diffuse axonal injury. And those cases can lead to someone in a coma now. And that's the
Hmm.
extreme. So
Hmm.
concussion doesn't have to be a blacking out. You could have concussion after a car accident or even after sport injury
Hmm.
and realize that you're off. And a lot of patients describe, "Well, I feel off. I feel like my brain is off." And sometimes they might not be able to articulate what that off means to them. And
Hmm.
sometimes we have to ask the family, "Hey, what's
Hmm.
so different about your spouse? What's so different about your son, your daughter?" And they can tell you, "Oh, they're acting differently." They might even show personality changes. "Oh, you know what?
Hmm.
My son is behaving differently. He seems too angry." That's not themselves.
Hmm. Hmm.
So an important, I think, aspect of understanding that concussion, one, does not you don't have to pass out or lose consciousness to meet concussion. And two, it's an acceleration, deceleration injury to the brain tissue inside the skull during some sort of a movement.
And does it preferentially affect any particular part of the brain? Like I would think that if it's, hitting the brain is inside this kind of what they say, like inside this hard case, that the edges of the brain might be more affected because it would hit the bony part of the cage. or is it, and all parts of the brain could be potentially affected?
I mean, the force of the impact can be coming from any direction, and we have this
Hmm.
phenomena that we call coup counter coup. And so
Yeah.
coup is going to be the area where maybe the impact happened, and counter coup is going to be on the opposite. So you
Mm.
could land on your right side of your brain, and if you hit on the right side of the brain, the coup will be on the right side, and the counter coup on
Mhm.
the opposite left side. And it
Mhm.
depends on which part of the brain most of that impact or the force of the
Mhm.
impact transmitted through is where you're going to maybe have more of those symptoms. But it
Mhm.
doesn't have to be specific, meaning not all concussions are the same. We've seen patients who have concussion
Mhm.
who primarily exhibit visual problems or eye
Mhm.
movement issues, vestibular issues. And there are times people have concussion that is primarily headache. I think headache is probably the most common symptoms after traumatic brain injury. But then you can also have depression, anxiety, trouble with
Mhm.
math. One common thing that I've seen a patient describe frequently is has to do with language. And they might describe, I seem to have a hard time finding the right word finding difficulty. They can tell you, I can see the word in my head, but for some reason I'm not able to retrieve it from my brain and translate it into a word coming out of my mouth. Or they might
Right.
say, my friends have noticed that in the middle of a conversation, I stop, I space out because I'm losing my ability to think of the words.
Mm. Okay.
So that's another form.
Right. And how would one, I mean, some of these are all just observable, the things you notice through observation. Was there any other testing that one could do to determine the level of the concussion, as a clinician or as
So for the most part, concussion is going to be a clinical diagnosis. That's a great question because sometimes patient can be referred to me and they say, well, doctor, my CAT scan was negative. They did a CAT scan or an MRI of my brain. They didn't
yeah.
find any bleed, any fracture, any problem. So how is it that I have concussion? So I say concussion is a clinical diagnosis, and sometimes your imaging studies, those testing will come back completely normal. Now,
Mhm.
there are other ways to try to like verify the concussion. Primarily, it's going to be through certain questionnaire, and there are some questionnaire established that we can use as part of a screening process to determine who had concussion. This history is going to be the most reliable way to identify that a concussion might have occurred based on the history
Mhm.
of the traumatic event itself and whether
Mhm.
they had altered cognitive function, not necessarily
Mhm.
loss of cognitive function, but an altered level of consciousness. And
Mhm.
then there are some tools out there that have been made that are available now that we can utilize. One tool that I use here in my office, for example, is called the iBox, and it's an
Mhm.
FDA cleared device where, by tracking the eyes, it's able to generate they call it the box score, and it gives you
Mhm.
a score, and that's depends on the score. We know if it's likely you have concussion or no. So, for example, if your score is above 10, you definitely had concussion. If it's less than
Mhm. Mhm.
3, you don't have concussion. And then
Mhm.
between the
Mhm.
two ranges, then you'll probably have maybe mild form of concussion or you're in your way to
Mhm.
recover from concussion. So there are some testing that we can utilize to quantify the degree of concussion with patient outside of the clinical assessment and examination.
Mhm.
Beyond that, there are some other testing that people will perform as part of a concussion workup, not necessarily to prove they have concussion, but maybe to rule out other causes for these symptoms. For example,
Mhm.
if someone had a concussion and one of their symptoms is dizziness or balance issues, well, how do we know that that dizziness or balance problem is not coming from an ear problem? Right? So then you might do specific testing for vestibular function to determine is it coming from the ear versus it's coming from concussion. So there are ways of ruling things out. Patient I saw this morning, one of their symptoms was feeling lightheaded as if they're gonna faint out, which you
Mhm.
probably recognize when we hear something like that in clinic. It makes us think of a vascular issue, maybe blood pressure issue,
Right.
low blood flow. So now
Mhm.
I'm going to say maybe we need to do a vascular study and get an MRA to look at the blood vessels that go to the brain and make sure that there is no occlusion or narrowing that's affecting the blood flow. So there are some battery of tests that we might actually have the patient go through in a process of is by process of elimination or exclusion. Let's eliminate these other organic possible causes for these symptoms. And
Hmm.
now the constellation of all these symptoms together in the context of a traumatic injury where there is a blunt force to the brain will make us feel now you have that concussion.
Hmm. Okay. I want to ask a couple of questions. One about um, so is there actual neuronal death, or are we just saying this is a synapse, decreased connections, or what do we know what's happening at that level? Like what's happening is when we have a
Uh,
concussion?
I mean, there are several things that could happen. And again, a lot of it just depends on the extreme of the
Right.
injury. I mean, some concussion cases, like we talked about diffuse axonal injury, which is really
Hmm.
severing or disruption of the transmission through the axons, and those sometimes you can see on the MRI. You can actually detect
Hmm.
diffuse axonal injury, so it becomes a structural, not just a chemical or
Yeah.
electrical signal issue, but it's an actual structural problem. Some of
Hmm.
those severe traumatic brain injury might also include things like bleeding. So there is a
Hmm.
head bleed and now there is
Sure.
something compressing on the brain. So the degree of what happens to the brain cells can vary based on the extent of the injury and the force that is inflicting the pressure or dysfunction on the brain cells. Now,
Hmm.
do the brain cells die? It would be extreme. Maybe they have a massive head bleed, and that massive head bleed now, by virtue of too much pressure, is causing, stroking of the brain cells. And so that would be kind of like, the extreme traumatic brain injury, where now there is brain cell or brain tissue loss because of a stroking event.
Right. I asked that question because I guess if there is if there is not if there is no neuronal actual death, then there's a chance of rehabilitation. I mean, we're always understand that that there's not necessarily so much new neuronal growth, but I guess that's where we're going to go into transmagnetic stimulations because I guess something's dead, it's beyond repair. That's would be my thinking. But if it's only some type of damage, then I guess there's recovery possible.
Yeah, and I think most of the concussion injuries, and again, by definition, when we use the term concussion, by definition, we're really referring to mild traumatic brain injury. Because
Mm.
severe traumatic brain injury, that would be things like where you have a Glasgow coma scale that is consistent with concussion and coma below less than
Mhm.
8. That's the
Mhm.
different category of traumatic brain injury that might require different form of treatments. But if we're talking
Mhm.
about like, the mild traumatic brain injury, a high school basketball player landed the wrong way, felt dizzy, lost consciousness, they took him out of the game for the next few weeks. Those sort of concussion, they do have the chance to recover. But having said that, the tricky part or what we don't know is how long is it going to take to achieve full recovery. And now we can go through different definitions. So most patients, we believe, for mild traumatic brain injury, that concussion is gonna maybe last for a few weeks, maybe up to 2, 3 months. Anything beyond the 3 months, any time a patient has symptoms lasting beyond that 3 month cutoff, we now call that persistent post-concussive symptoms or
Mhm.
post-concussional syndrome. So now you
Okay.
go from having a symptom, it becomes a
Yeah.
syndromic condition, and the longer these symptoms last, the longer the recovery will take, which is why it's very important to recognize concussion as soon as possible so you can initiate therapy as early as possible. And that way you can achieve faster recovery.
And if somebody does make a full recovery, I understand they're still at risk for more severe concussion if they have some type of head trauma. Is that correct? Or that if somebody makes a full recovery, they're at the same risk as someone else for a future head injury?
Yeah, and I think maybe this is more of the top of repetitive traumatic brain injury. So if you
Hmm.
had your first concussion, for example, uh,
Hmm.
uh, your second concussion could be more impactful. So maybe now you're more vulnerable. The symptoms, the second time around, the symptoms might be more intense, more severe, and they might last a little longer than the first time around, and the recovery might also take a little longer. And so that's one thing when we evaluate patient. Well, how many times have you had concussion in the past? And interestingly enough, patient recognize that. Patient who had suffered multiple concussion, they'll tell you, I had concussion when I was in high school, and I recovered from that fine, whatever fine means, right? And now I got another concussion, and this feels a lot worse than the first one.
Yeah. Yeah.
And
I
and
wonder from people who have like minor head, repetitive head trauma, and it just feels like, yeah, they're much, even if they feel they're recovered, a small head trauma feels like a concussion.
yeah, and sometimes because it's hard when we do, let's say, like a 30-minute or an hour evaluation with the patient, the brain controls so many functions, and sometimes it's very hard for us to address or assess all different aspects of brain function in that limited time. There
Hmm.
are times we're going to rely on performing formal neuropsychological testing, and those testing are extensive. You're talking about now multiple hours where they're testing all different aspects of brain function
Hmm.
that now allow us to quantify the extent of brain dysfunction in different aspects of not just cognitive, but calculation, writing, reading, multiple aspects. And those tests, like I said, they can last for hours. So
Hmm.
even though, to your point, the patient might feel that I feel like I fully recovered, but you put them through a specific test that they haven't really put themselves through, because I don't do calculation every day, for example, right? If I don't do calculation every day, how do I know that that aspect of my brain function has been impacted until you have
Hmm.
them do math? And now they realize, oh, I was able to do this quickly. Now I can't.
Right.
So to your point, they might think they're fully recovered, but there are certain aspects of their recovery that they don't recognize fully recovered yet because they're not
Hmm.
testing those brain functions at the time of full recovery. Neuropsych testing becomes useful in quantifying those deficits, those area of
Right.
deficits.
Okay, so let's move on to transmagnetic stimulation now of the brain. So maybe take me through the history of that. Uh, you know, when did this first start? What are the approved indications, and what's the mechanism of action?
So to draw some, I guess, similarities to some extent, we can go back to ECT, electroconvulsive therapy, and some of the listener might be familiar with it. The younger people might not even know what that is, right? Just like, my kids don't even know the old rotary phone, back in the days. But in the 1930s,
Hmm.
electroconvulsive therapy came to exist in
Right.
the 1930s, and we're using electrical energy to pretty much help people with psychiatric illnesses. But electrical energy can be very harsh on the body. I mean, I remember back in med school when I did my psych rotation and we would go to this ECT treatment. Uh,
My God, it was very hard to see that. I used to
exact,
find that
right?
people were just came back duller. I mean,
Yes.
my sense is that it was like a reset. It was just like we were told, okay, we're just going to reset their brain. They're going to restart up again. It's like a reboot. Like we turned
Yeah.
off the computer and
Yeah.
restarted. But yeah, that
I,
was pretty scary treatment, really.
especially when you're a med student, I've never seen anything like that. And the first time you go there, and to me,
Hmm.
when I describe it to people now, it's like, do you see, like, when you watch these medical shows like ER or
Hmm.
Grey's Anatomy,
Hmm.
and then they try to resuscitate someone heart,
Yeah,
they have a cardiac
yeah,
arrest, and then they shock them. It's the same thing, but you're doing it to the brain.
yeah.
So kind of like, you're giving this high energy to the brain cells. So that was ECT, right? And then in 1985, I believe it was around 1985, which is now we're talking about like a few decades later, someone genius came up with electromagnetic or TMS, transcranial magnetic stimulation. So 1985 is the birth of TMS as a field. But then in the United States, it took over 20 years, almost to 2000, until 2008, I believe, when the first FDA clearance was granted to use TMS for major depressive disorder.
Mhm.
And then 5 years later, in 2013, it got FDA clearance for migraine headaches. And then in 2018, it got FDA clearance for OCD, compulsive disorders. So it has started to gain recognition and FDA clearance for different aspects slowly. But the TMS is now 40 years old because it was in 1985 when it was invented. We're now in 2025. So it's a 40 years
Yeah.
old technology. What's
Mm.
difference is different companies will use this technology and how they deliver the TMS could be different from one company or one device to another device,
Mm.
and how the energy is delivered,
Right.
and what goes into the design of the machinery and so
Hmm.
forth.
Hmm.
Now, in the United States, FDA clearance in the United States is different than, let's say, the clearance in Canada.
Yeah.
In the Canadian market, they might have different indications or clearances versus the United States. I think major depressive disorder in both countries, TMS is cleared for major depressive disorder in both countries. Where there's certain other disorders that might vary from one across the border.
Yeah. So, so this, let's say the magnetic stimulation is a form of energy. And apart from electroconvulsive therapy, which is a huge jolt of, burst of energy, which in effect, I think kind of resets the whole thing. I mean, the idea here is quite different. I understand that magnetic stimulation of that brain is in effect, from my understanding, is just stimulating the activity of the neurons. Is that correct? Is that how we think it's working?
Yeah, if you think of the neurons or the brain cells, they're nothing but cells that are responsible to transmit an electrical charge from point A to point B. They're
Hmm.
essentially electrical cables to simplify to the listener. Think about these brain cells, a
Sure.
bunch of electrical cable. They transmit electricity from point A to point B. The question is, how do we generate that electricity? So ECT was actual charging electricity by delivering electricity, right?
Hmm.
Now, in transcranial magnetic stimulation, what makes it non-invasive is that the magnetic energy is transmitted across the skull. So instead of penetrating the skull or opening someone's skull, no, the device is actually sitting on the outside, on top of the skull, and the magnetic energy is getting transmitted through the skull to the brain tissue. People who are familiar with, let's say, MRI or had MRI studies, they go into the MRI machine and the magnetic energy is able to capture a picture of their internal anatomy, and that's how we get MRI images. And they can tell that the magnet, aside from being maybe it's claustrophobic to some patients, maybe it's a little too noisy, you don't feel anything like hurting your body, right? Like there is no
Hmm.
heat or thermal heat, injury of some kind. So
Yeah.
now the magnetic field are penetrating to the brain tissue. By altering the magnetic fields, that alteration of the magnetic field can create depolarization and repolarization across these nerve cells. And that differential grade between depolarization and repolarization is what now create electrical pulse by changing in the sodium channels, potassium channels, and so forth. That would allow these charges to move in and out of these brain cells in a way that now you have an electrical charge. Now that electrical charge will now get fire will transmit through that brain cell. So essentially, you're creating the electricity by manipulating the magnetic field, which is non-invasive, non-painful to the person.
Why do you think that giving, like, just is it just giving energy or giving, making these neurons depolarize has a benefit? Like, why should that be a benefit? How do we know that we're always creating a benefit here? Like, why, what could we be making a condition worse? I understand that, people have seizure disorders can cause seizures, but it just seems like kind of surprising that it could work in so many different conditions.
Yes, and you're absolutely right. It is interesting you say that because, to be honest with you, I mean, there are a lot of things that we might not fully understand, but we know, at least in theory, or at least the physics behind it, that if I'm able to generate electrical pulse or charge through that nerve, I'm helping the nerve do what it's supposed to do. Now, if
Mhm.
I'm delivering extra charge than what the nerve needs, that might get us in trouble. We
Mhm.
always use the statement, everything in moderation is good, right?
Mhm. Mhm.
Exercise in moderation is good. If you don't exercise at all, that's not good. If you over-exercise, you might actually sprain your, muscles, ankles, and you hurt yourself. So
Yeah.
the way I see it, that's I think the art about clinician understanding how they deliver these treatment by
Mhm.
understanding the level of energy that you need to deliver that is not going to create brain fatigue. And that's an actual phenomena. There are patients that after a TMS session, they'll tell you, man, I feel a brain fatigue. It's no different than I went to the gym and the trainer, my personal trainer, was a little too harsh on me. And now I go,
Yeah, I felt that. I mean, I've done the treatment myself, and sometimes you feel a little tired, maybe a little tired,
yeah,
potentially
you
a bit
exactly, yeah.
tired,
Right, yeah,
And I
because
think, and we have the other BTL machine of the M-Sculpt and M-Cella devices, which work, I believe, on the same type of magnetic frequencies, and that's in effect muscle workout. That's a muscle workout. So
yeah.
I suspect this is a neuronal workout.
Exactly. And you said it perfectly, beautifully. Like how you do is the electromagnetic stimulation for the muscles. If you
Mhm.
overdo it,
Yeah.
patients are gonna have cramps
That's
and
why we need
muscle
3 days
spasm.
break for your body to recover, and they're
Exactly.
spaced out treatments. Yeah, that's
Exactly.
very interesting. Yeah.
Yeah, so the brain
Um,
cells are no
mhm,
different. You just don't want
mhm,
to like, stimulate him, overstimulate him to the point
mhm,
where now they become tired, for the lack of better
mhm,
term, what we call brain fatigue or mental fatigue.
mhm,
And
mhm,
like you mentioned earlier, in some
mhm,
cases, you might be actually overstimulating part of the brain that will now
mhm,
result in hyperactivity in the form of a seizure disorder or a seizure.
mhm. Right. So the way that the Exomind machine was working, that they're putting the device over the left prefrontal cortex, dorsal
Yeah.
prefrontal cortex. So that's I believe the area that's involved in mood regulation and executive planning, which we see, I guess, problems in a lot of mental health issues. But if we're trying to stimulate other areas of the brain, let's say, for example, someone's recovering from stroke or has another issue, would we not put that thing over a different part of the brain?
And that's actually, I'm glad you bring that up because that's kind of like the area of huge interest right now. Now, for major depressive disorder, mental health, mental illness, and
Mm,
mental health in general, the left dorsolateral prefrontal cortex, specific part of
mhm,
the brain, is the target area. And I try to explain to my patients that think of that part of the brain, we call it an association region of the brain. It's like if you were in New York City, it will be the equivalent of the Grand Central Station. It's a relay station. It is
mhm,
a place where all trains, all buses are coming from different regions to take you to other
mhm,
part of the city as well. So it connect to multiple part of the brain, and that's why it's involved in mood regulation, executive function,
mhm,
cognitive function, and so forth. So that's why it's heavily studied and targeted. Having said
mhm,
that, to your point, let's say someone had a stroke and that stroke affected their right arm. So the right arm is not working. And you would say, well, let's stimulate the left motor cortex of the hand area. And as a matter of fact, we know that that can happen because part of the brain mapping, as you know, because you have the device, when you do the Exomind, in this case, the Exomind,
Yes,
the
that's right.
first step
Mhm.
is brain mapping. And how do you
Yeah,
map the brain? You stimulate, you see the twitch, the
the
movement.
right hand. Yeah.
So you know
Mm,
that if you kept that applicator, that magnet in that on that motor cortex and just turn it on,
mhm, mhm,
that patient hand is going to continue to move throughout the whole treatment. So in theory, if I did that to someone who had a stroke and the right hand was weak, I might be
mhm.
actually activating, stimulating that hand, and maybe I'm going to help wake up, rehab these nerves and help the stroke patients. Now,
That's
I say
interesting.
that carefully because
Mhm,
obviously it's not FDA cleared for that purpose, at least. Having
mhm,
said that, if you look up TMS with other medical brain condition, including stroke, you're going to actually see that there is research that is being done with some preliminary promising results.
mhm,
So
mhm,
yeah, it's a great area of interest, specifically, like I'm very interested in exploring these areas.
Mm-hmm.
And I can give you a little bit of my background. When I was in
Sure.
residency, I trained in Syracuse, New York, and during my residency, my first few years in residency, we did direct cortical brain stimulator for patient after stroke. Now we would do
Mm-hmm.
these fancy brain surgeries where we
Mm-hmm.
literally remove a piece of the skull over the motor cortex, and we will lay down an electrical grid
Mm-hmm.
over the cortex. Part of it is covering the motor cortex, part of it is covering the sensory cortex, and it has
Mm-hmm.
this wire that connect to a battery, kind of like a pacemaker, but for the brain, let's call it, right? And
Yeah.
then we can actually power that and turn it on and make some adjustment, and we can actually control the movement of the opposite arm. And that was our way of studying if we're able to rehab these patients by putting a direct cortical stimulator on their brain. Now, this is
Mm-hmm.
back years ago when I was in residency. Move
And did
forward.
it help? Did it help?
Oh, it did help. Yeah, these patients were actually regaining strength and function in their stroked or weak part of their body. And we would see it as resident.
So no question. I mean, post-stroke rehab. I mean, I've read a book. I forgot which book it was. It's Ram, the very famous neurologist, who talked about that. That if you really made proper exercise of the affected part of that brain, you could really rehab. I mean, that we could have much better recovery than we do now. I
Oh,
mean, in
100%.
traditional stroke rehab
100%.
programs.
And now here is the fascinating part. I'm going to throw this as more of a for us as a mental exercise to see
Hmm.
if we're ever going to get to that point, which I believe we can and we should. What if
Hmm.
now that same patient we've been talking about, the theoretical patient with a stroke with the right
Hmm.
arm, right hand being weak,
Hmm.
you found a way to stimulate the brain non-invasively through something like TMS. And now you're doing something that is far more advanced and less invasive than what I was doing as a resident through an
Hmm.
open brain surgery with a
Hmm.
battery powered, right? You do that where you're working on the brain tissues, and at the same time, you're also treating that patient upper arm or right hand using something like the EMS, like the NEO, where you're now
Right.
rehabbing the brain and rehabbing the muscular system through these magnetic field, magnetic energy, one focusing on the brain tissues, one focusing on
Mm.
the muscular tissues.
Hmm.
Now you can
That's
talk
interesting.
about this non-invasive rehab program that include
Hmm.
TMS as well as EMS.
Hmm.
Right.
Wow. That's
So
yeah.
you can,
That would be huge, huge hopes to I think millions of people. I mean, the amount of
yeah.
I think suffering people have and after stroke is incredible.
It is fascinating. Now, like I said, I think there is, we're gonna continue to learn more about this as
Hmm.
I think more centers are doing research and looking into these fascinating areas of brain
Hmm.
health in general. And that's what I
Hmm.
said earlier. I think we used to think of TMS as more of a technology geared towards mental
Yeah.
psychiatric health,
Yeah.
but you can look up TMS now and you can see that it's involved in all kind of other neurological issues outside of psychiatry,
Hmm.
neurological, physical medicine and rehab, addiction
Hmm.
medicine, and so forth.
Hmm. This is I've read this is a longevity podcast. What do you think about people who are just generally healthy? Like, do you think we can actually improve our brain function just by doing TMS and just the regular aging? We're all having aging, and our brain is not what it used to be. What do you think about that?
Well, it's interesting you bring up the longevity thing because I've been actually over the last week, I've been kind of like asking myself that question. Well, what is longevity? And we think about
Hmm.
longevity. Is it longevity in terms of the number of years we live? Is it longevity in
Hmm.
terms of the function, our function? I
Hmm.
think of certain, like for example, athletes, and
Hmm.
I'm a big soccer. I follow soccer, so I'm going to use Cristiano Ronaldo, right?
Hmm.
Probably
Sure.
Cristiano. So Cristiano Ronaldo, he's already in his 40s, but the guy was able to invest in longevity in his career as a soccer player, where he's able to actually compete with
Yeah,
people who are much younger in chronological years.
that's right.
So what I started thinking about this word longevity and aging, and what is aging. So I started thinking of it. I had to force myself to think differently. So to simplify it, I look at it in terms of there is chronological aging, which we
Mhm.
cannot change. 5 years from now, we're both 5 years older.
Mhm.
And that's just 5 years added to our clock, our time, right? That we can't change. But then
Mhm.
this concept of functional aging
Mhm.
might be also playing a role into this overall aging process. I'll use the example of you and I bought the same car model.
Mhm. Mhm.
2025, January 1st, you and I went to the same dealership, bought the same twin cars, exactly the same. In
Mhm.
5 years, they're both 5 years old chronologically, but
Mhm.
you were very careful with the car. You only drive it out on the weekends and you maybe put like, a few miles a month on it. On the other hand, I'm taking it off-roading and the
Mhm.
snow and I'm just beating this car. In 5 years, my car went through more functional aging from
Yeah.
the wear and tear than your car. So it's much
Sure.
older. So to your point, I asked the question when we talk about mental health. There is chronological aging in terms of how old the brain is based on our age. But
Mhm.
is there a functional aging that happens to the brain based on what we expose our brain to? And I'll use the example of, let's say, the generation we're in now. You and I probably grew up at a time when we didn't have cell phone and iPad and
Yeah.
talk and Instagram. For us, our mental exercise was maybe tic-tac-toe or, something like that, right?
Mhm.
Or doing puzzles. But
Mhm.
now think about the amount of information that your brain is getting exposed to, and not all of it is good information that's enhancing your brain. Some
Mhm.
of this information that's coming to your brain, overwhelming your brain, burdening your brain, is junk information.
Yeah.
And I can tell you the first time I tried the Exomind myself,
Mhm.
after that first session, it literally, the closest thing that I can describe it to was
Mhm.
it almost felt like you went to your computer and you hit
Mhm.
Control, Alt, Delete,
Mhm.
and you
Yeah.
rebooted that computer. And now
Mhm.
the performance is a little better. It's actually
Mhm.
better because you were able to empty the cycle bin,
Yeah.
right?
Right. Right. Right.
So the
Interesting.
question that I always ask, what is it that we do day to day for our brain to recycle the brain?
Mhm.
We recycle waste, we
Mhm.
recycle papers, we
Mhm.
go to the gym to recycle our muscles. What
Yeah.
are we
Yeah.
doing to recycle our brain function? Not necessarily
Mhm.
like, building new brains or,
I
but
guess it would be sleep maybe if people get a
that's
proper
part of
sleep.
it.
That's a yeah, and maybe meditation, mindfulness
Yeah,
potentially could be
yeah.
important too. But I think this could be another huge opportunity. This is like you're right, type of a TMS could be a part of solution for that for the brain. Yeah.
Yeah, and it could be that form of brain exercise by
Mhm.
actually using magnetic energy to charge
Mhm.
up the brain cells,
Mhm.
right?
Mhm.
So to me, I don't look at even though we've been talking so far about TMS in terms of as a medical
Yeah.
tool to treat medical condition, there are times
Mhm.
when I look at it and view it as a wellness tool,
Yeah.
right?
Yeah. More like a lifestyle treatment. Yeah.
Yeah,
Hmm.
lifestyle wellness. And I've
Yeah.
had I've had a few of my patients, clients, I guess, that literally came to me and said, Dr. Abdulhamid, I don't have a mental problem, or at least I don't think I had a mental problem, but I
Hmm.
just feel like I need something to help my brain think better, focus better. I'm
Hmm.
overwhelmed with all kind of, again, all that information coming to your head from work,
Hmm.
family, friends, and so forth. And I
Yeah.
can tell you this, they will do this treatment, and upon completing the treatment, they will come and tell me, listen, after this treatment, I felt more focused, I felt like more concentrated and more motivated. I shared this with you, and this might actually surprise you.
Hmm.
Last week or 2 weeks ago,
Yeah.
my office manager, when we got our TMS several months ago, we wanted to
Yeah.
test it on all of us. And when
Mm.
I wanted to, when I went ahead to, we went ahead to test it on her, but for whatever reason, we could not get the motor strip, that threshold. She
Hmm.
wouldn't react to it. And
Interesting.
she, I guess, took it personally all this time because she felt like, well, maybe my head is wrong. Maybe there's something wrong with my brain. And I kept reassuring her, it probably was nothing about your brain. You're fine, right? So
Mm.
2 weeks ago, she came to me and remember, we've had this for a few months, but you can tell how
Mhm.
much it bothered her all this time. So she came to me, she said, Dr. A, can we try it one more time? I was like, try what? She goes, that Exomind thing, man. I can't believe I'm the only one that this didn't work for. I was like, fine, let's try it. So we tried
Okay.
it this time and it worked. So obviously we were fine. So we gave it that full session of 24 minutes, 30 minutes or so.
Mhm.
And then we did this first thing in the morning. It was around 7:38 in the morning.
Mhm.
Now, I've been working with her for 8, 9 years now. And
Okay.
usually by 1, 2 p.m., we all hit that like
Yeah.
early
The dip.
afternoon and things start to
Yeah.
slow down
Tired.
after lunch, right?
Yeah.
That's I think the siesta in Europe is the reason for siesta in Europe because you need
Exactly.
that after a meal, right? We don't have that here. So things
Mhm.
slow down. Now, that day in particular, it was 4 p.m. and she was more energetic, more focused than any other
Mhm.
day that I've seen her before.
Mhm.
And so I
Mhm.
talked to her, I said, listen, do you feel any difference? She said, you know what? No, I'm on the go. Let's go. Like let's keep doing work, task, all the stuff. So then at the end of the day, I told her, hey, listen, you know what's so interesting? I was just observing you throughout the day. You didn't seem slowed down. You didn't seem tired. That afternoon fatigue or tiredness, you didn't have any of that. And then she shared to me, she said, you know what? It's interesting you say that because throughout the whole day, I was able to multitask better than
Mhm.
I was able to do so prior. So check this out. On my way
Mhm.
back, we just had lunch together and we're coming back here for our meeting together.
Yeah.
And we had lunch. And
Yeah.
I can tell as we were finishing our lunch that she started getting these droopy eyes, like just getting that. So as we were heading back to the office, she goes, "You know what? You know what I need now?" I goes, "What?
Right.
Coffee?" And she's like, "No, I need an Exomind session."
Okay. Yeah.
Because she
That's the
knew
best.
yeah.
Yeah. That she can
So,
see that. I think that's what I think are it's good when people can see those impacts and it sounds like people are seeing the effects of the machine. So that's pretty impressive.
yeah.
Um yeah, that's really exciting. So my thing is that you're I guess continue to research in this whole aspect of the other uses of TMS. Is that correct?
Yeah, I
That's
mean
kind of
now
your space.
now in my office, I mean if someone come to our office, I mean we do a thorough evaluation. So anytime
Hmm.
someone has come to the office, we're not just looking for the back pain. Most patients come to me specifically for spine-related problem, neck pain, back pain,
Mm.
sciatica,
Right, right, right.
the common back spine-related issues. But I
Hmm.
realize that as physician, we might have lost huge opportunities in helping our patients by addressing other aspects. And in the past, that might have been okay because we didn't have tools that made it easy for us to deliver these treatment in non-invasive ways.
Yeah.
But now I realize by just asking the right questions, we know, for example, in the area of back pain, we know there is a strong correlation between mental health and chronic pain. People who have
Yeah.
chronic low back pain, they can develop depression and anxiety and
Right.
mental illnesses, and vice
Hmm.
versa. People who have mental disorders, they can now perceive back pain and neck pain or knee pain and joint pain in ways that are different for the average person to understand. And you probably remember this or know this. Sometimes we would call, oh, patient will come to you, doctor, everyone told me it's in my head. Everyone tell me the pain is in my head. And interestingly, we say, oh no, which unfortunately that meant maybe I'm quote unquote crazy because no one can explain to me why I'm in so much pain. And the
Hmm.
reality is maybe it is true that the pain is in your head in the form of a psychogenic pain, right?
Mm.
A
Interesting.
psychologically mediated pain because of
Hmm.
underlying depression, underlying anxiety,
Hmm.
that even though the patient didn't have those mood disorders,
Hmm.
living in chronic pain ended up causing them to develop those conditions, and now it became
Mm.
in their head. So now
Right, right,
part of
right.
my screening is I look at these matters. Do you
Mm.
suffer from depression? Do you suffer from anxiety as a result of the
Hmm.
chronic pain condition you've been dealing with?
Hmm.
The answer in most cases is yes. In the
Hmm.
past, what did I do to help these patients? Well, maybe go to your primary care doctor, family doctor. They'll give you some antidepressant
Yeah.
medication or go get a
Yeah.
psychological evaluation. Well, now
Mm.
with something like TMS that is non-invasive, no anesthesia, no pills, no drugs needed, they lay down and just have this device just touch their scalp and
Hmm.
see if that gives them their relief. So now all
You
of
could
us,
give pain relief, you think. You think it might help with pain relief.
we've actually had patients who've had
Hmm.
chronic back pain just
Hmm.
by helping their mindset by using Exomind TMS and
Hmm.
help them relax, lower their depression or anxiety level. Their
Right.
response to other treatments that
Hmm.
was geared towards their back pain became more effective.
This is a little bit of a crazy question. Do you think that we can stimulate the spine directly with magnetic stimulation?
Uh,
Or it
Interesting.
doesn't?
That's an interesting concept. I don't know. I don't think it's been tested. I think the short answer to that is probably yes, because if you're
Mm.
generating magnetic field, you might be
Hmm.
able, you should be able to alter the charges around the nerve cells for an electrical charge to transmit. The only
Hmm.
question, I don't know how we're going to be able to do that. Unlike the brain, where you have these massive surface and you can
Mm.
map different part of the brain,
Hmm.
all of the function, motor, arms, legs, sensory,
Yeah.
all of them are really concentrated in a tiny, tiny space for us to isolate that.
Mm.
But to your point, we do have, and we've had this for years now, the field of neuromodulation and using things like spinal cord stimulators. So a
Yes.
spinal cord stimulator device, it's a
Same
device
idea.
that we implant on the spinal cord to
Yeah.
create that electrical charge
Hmm.
being
You could
on
put
the
a
spinal
magnetic
cord.
charge. Yeah. You could put a magnetic charge there, I assume.
So the question is,
Hmm. Hmm.
what if we, like we talked about me back in the days doing direct cortical stimulator, now we can
Yeah.
use TMS. Maybe at
Hmm.
some point in time, to your point, in the future, we'll
Hmm.
have something that will replace spinal
Yeah.
cord stimulator from electrical device to magnetic device that can go on the back and do it.
Wow.
And,
Yeah.
and
Okay.
I personally believe that that is done even through things like the M-Sculpt Neo because it's a
Mm.
magnetic energy, magnetic
Exactly.
stimulation. Question is how to
Exactly.
prove it.
Right. Well, I think that's a perfect ending to this, I think, interview. But how can people get in touch and learn more about your practice at work? Is you have a site or
Yeah,
website
I
or
mean, yeah, you can
social
go
media
to
for?
royalspinesurgery.com. That's kind of like
Okay.
our website. And then
Okay.
it's in social media. I mean, people reach out on Instagram a lot, I guess. I didn't
Okay.
even
What's your handle? What's
uh,
your handle?
the dot Dr. Dr. A. The Dr. A, with the dot separating the
Yeah,
doctor from A. But
yeah. Okay. Perfect. Thank you so much, Dr. A. I appreciate your time today, and it was really informative. I learned a lot, and we'll have a quick offline about treating some stroke patients. I'd love to learn a bit more about that. Thank you
yeah,
so
yeah,
much.
keep it posted. Like I said, it's
Yeah.
fascinating. I'm always excited about exploring the potential for these technologies and taking to
Mhm.
think outside the box and how we can apply them in other areas to help more patients.
Okay. Thank you so much.
Cool. Well, thank you for having me.
And I hope you enjoyed today's talk with Dr. Abdul Hamid. We learned a lot today about this new technology called transcranial magnetic stimulation and how it's being used apart from the approved conditions of anxiety, depression, OCD, binging, and cravings, as well as being used for some new conditions such as stroke rehab, Alzheimer's, and Parkinson's. So a lot of research is happening in this field, and you can learn more about transcranial magnetic stimulation by looking up Dr. Abdul Hamid, as well as looking at the device called Exomind produced by the BTL company. Uh, this is something definitely keep your eye on as more people are looking for non-drug treatments for their brain conditions. We'll talk to you later. If you enjoyed today's talk, make sure to like, subscribe, share it with your friends and family. That helps us get the rankings up on our algorithm and making sure that more people see this information we're bringing to them. Take care. If you enjoyed today's podcast and you felt you learned something that can help you on your journey, please hit subscribe, like, and I'd love it if you'd share this with a friend.
who you think would also benefit and get inspired. And leave us a review. We're always looking for feedback on how to deliver more value to you. So take care. Until next time, I'm Dr. G from Peak Human Labs Podcast.